Frankie.
Thank you, sir, for the kind introduction. And thank you, Dr. Diksha, Dr. Nayan, for discussing the initial part. Post-lunch sessions, especially pediatric cataract, can be really drowsy for a lot of individuals. But I'll try to make it as interesting as possible. Post-operative care and rehabilitation of pediatric cataract patients. So just after the surgery, post-operative medications are given, topical steroids, pred-acetate, which is usually tapered weekly. So we usually give that for a period of 6 weeks. Cycloplegics, for children less than 5 years of age, we usually prefer eye ointment atropine. And for children more than 5 years of age, we are using home atropine, which is given QID for a couple of months. And topical antibiotics are usually given for a month. Now, from where a pediatric cataract differs from an adult cataract is basically post-op. Post-op is the key for managing a pediatric cataract patient. We have to schedule the follow-up in such a way that we see the patient on post-op day 1, do a good distant direct ophthalmoscopy, measure the retinoscopy, and prescribe glasses as soon as possible. Our colleagues from the West may differ with us, and they may want to prefer no IOL or just contact lenses. In Indian subcontinent, because of socioeconomic strata, not all patients would be very compliant for the follow-up. So it's not a bad idea to implant IOLs in whichever case which is possible for us, which I'll be discussing with you. We thereafter see the patient on 1 week and 1 month. Thereafter, we have a 2 to 3 monthly follow-up for the initial 6 months, then 4 to 6 monthly follow-up for the next 3 years. Infant aphakia treatment study talked about the follow-ups at day 1, 1 week, 1 month, 3 months, and every 3 months. The key of preoperative counseling to these parents of pediatric cataract is the child would need a constant regular follow-up to look for VAOs, to look for change in the refractive error, to give the glasses, change in the prescription of glasses or contact lenses on a sequential basis, and also to look for any complication developing because of the surgery, which we try to minimize with our good preoperative planning. On post-operative day 1, we do a distant direct ophthalmoscopy, observe the glow. We look at the status of the anterior chamber with torchlight or slit lamp if the child is cooperative. We do a refraction testing using a handheld, either using a handheld refraction bars, or we can use separate prescription glasses for the same, and we immediately prescribe glasses at our setup. In unilateral cataracts, you have to jolt the system. When the kid is small, it is like a wet clay. There's a lot of neuroplasticity, so you want to cash in on that neuroplasticity, and you want to patch the good eye so that you jolt the visual system of the now operated eye. Post-operative 1 week, we again look for the glow. We confirm the compliance of glasses and patching with the parents. We taper the medications as has been discussed previously, and we check for the improvement in fixation. We check for visual acuity on Cardiff or Teller's visual acuity cards for young children. Post-operatively at 4 to 6 weeks of age, we do examination under anesthesia where we do suture removal. Most of the times we are doing superior surgeries. So when we are closing the wound superiorly, we are inducing with the rule astigmatism. So you want to remove that induced cylinder by removing the sutures, assess for any visual axis opacification, do the biometry to cross-check your retinoscopy, intraocular pressures, and fundus evaluation. At every possible visit, at least for 6 months, look for biometry and refraction. And if there is a poor red reflex, we take up the kid for examination under anesthesia. And if there is significant visual axis opacification or VAO, we do a media clearing membranectomy. If it is anterior to the IOL, we can go via the anterior route. If it is posterior to the IOL, we make a pars plana port, single pars plana mode, and clear the proliferative VAO from the posterior surface of the IOL. And if there is a gross unexpected refractive error, which is too off from our prediction, then we can go for an IOL exchange as well. Visual rehabilitation, either with glasses or contact lenses, is quite important for the refractive correction. And the second most important part is amblyopia management, which is given via occlusion therapy and active vision therapy. Glasses, we have to make sure the parents are counseled about the importance of compliance with glasses, as we are undercorrecting these kids. We are shooting up for powers which we want the child we are trying to attain for parts which the child will have when the eye grows. So it is important to give the adequate refractive rehabilitation. If the glass is unequal or heavy on one side, as I can show you in this image, the glass is too big for this child. So in such a scenario, we have to counsel them that use appropriately sized glasses and do not and use high index glasses, so that the thickness of the glass, especially when you're under correcting and you're giving a prescription of +8 or a +10 or a +12, you need a high refractive index glass so that it is thin and comfortable for the child to wear, so that the lashes do not hit the glass. Additional supports can be used, as you can see in these images: cable tampons, goggle converters, or overnet harness for kids who are quite active, who just want to throw the glasses off. But you will be surprised to know, in our clinics, when we are following up these kids, they are actually, when they're able to see good, they are quite compliant with these glasses. The only important thing is the adequate sizing, proper refractive index, and the comfort of the kid with the proper size fitted frame. Aphakic glasses can also be a difficulty, so we have to use a small frame. We should ensure that the line of vision should rest close to the center of the lens, and the frame should have adequate sufficient depth to accommodate for the thick lens, and spring hinges can be used to absorb any impact and to snugly fit the glass. Contact lenses can be used, as has been described in IATS: silicone elastomer lenses, rigid gas permeable lenses, hydrogel lenses. But in this part of the world, in the third world countries as well, the socioeconomic status might not allow the parents, the hygiene might not allow the parents. We have also tried this, but we have burnt our fingers, where the kids actually ended up back to us with infections, keratitis. So it's not a bad idea to put the IOL, if the biometry allows, and then give proper contact lenses. Yes, contact lenses have been tried in educated parents who are able to maintain hygiene and change the contact lens frequently. For amblyopia management, you have to jolt the visual system. There is pre-op deprivation and there is post-op anisometropia. Both of these have to be dealt with amblyopia therapy. The aim is to provide a clear retinal image with proper refractive correction and then correct the ocular dominance by patching the good eye. You can give a corollary of a twin-twin transfusion syndrome, where the good twin takes up all the nutrition from the other twin. So it's a similar scenario where the other eye did not get adequate support from the visual system, adequate supply of the vision. So we have to jolt the system by patching the good eye, so that during this age of neuroplasticity, the child can improve on the lines on the visual acuity chart. The amount of patching is dependent on the age when the retinal image is clear. Occlusion therapy can be partial or total, full-time or part-time, converse or inverse. The occlusion goals are differential diagnosis, improvement of amblyopia, elimination of suppression, awareness or elimination of diplopia, and disruption of anomalous correspondence. The full-time occlusion can be used initially to jolt the system. Age-appropriate guidelines can be used for age 1, 2, 3, 4, 5. It can be 1:1, 2:1, 3:1, 4:1, where the other one is to prevent the occlusion amblyopia. For more than 6 years of age, full-time occlusion can be tried as 6:1. It is better in preschool children. The risk of occlusion amblyopia is always there. That's why there's a need for constant follow-up and counseling of the parents, and faster recovery with shorter duration of time for full-time occlusion. Now gradually you can taper it to part-time occlusion, and this gradual shift from full-time to part-time would actually also aid in the binocular perception of the visual system of that child. There's always a risk of occlusion amblyopia, so you have to check the visual acuity of the better eye, if it's dropping or not, and counsel the parents accordingly. If there is an occlusion failure, the definition is that there is no improvement in best corrected visual acuity in the amblyopic eye on 3 bi-monthly follow-ups. The factors which are common for occlusion failure are poor compliance, age more than 6 years of age, where neuroplasticity wanes off, visual acuity in the amblyogenic eye less than or equal to 20/200, or astigmatism of more than 1.5 diopters. Active vision therapy can also be tried in the form of near vision tasks and fast pointing activities. Certain video games have also been introduced recently as a form of next generation technology, and the possible role of re-education of the amblyopic pathway by intense sensory and motor interactions is known to stimulate the visual processing and enhance the plasticity of the visual cortex. So Active vision therapy can be tried as a monocular treatment, where you can use perceptual learning or monocular video game, or dichoptic treatment like dichoptic perceptual learning and dichoptic video game play. Now, what about certain complications as I talked to you about? Visual axis opacification, or if during the initial time of surgery, the biometry didn't allow us to put an intraocular lens. The indications for aphakia at our center is small eyes where the white to white is less than 9 mm and the axial length is smaller than 17 mm. We tend not to prefer to put an IOL. When the eye grows, we plan for a secondary IOL. We do a EUA for biometry sequentially on the EUA follow-up and the UBM for sulcus assessment. The ideal scenario would be an IOL in the sulcus in such patients. Now, what are the prerequisites for a secondary IOL? I would say 3. Sight, the best corrected visual acuity. Second, specular count, which the very small kids may not allow, but the corneal clarity would give you a clue about the specular status of that eye. And thirdly, most important, the sulcus support. The sight should be significant enough and there should be significant improvement with the intervention, which we can check with the refractive rehabilitation which we are giving. Sulcus can be assessed with the help of ultrasound biomicroscopy to look for the rim of sulcus. We are frequently using 35 megahertz probe, and the anterior chamber assessment during UA for any peripheral anterior synechiae, shallow anterior chamber or posterior synechiae. Now here's a video courtesy to Professor Sudarshan Khokar, where in an aphakic eye we are implanting a secondary IOL. You can see we are releasing the posterior synechiae initially with the help of a Helon or OVD cannula, enlarging the incision, putting some OVD to create a space, and then injecting the IOL slowly with the leading haptic going in the sulcus and then gently turning the lens, because there's always a torque with 3-piece lenses. So you have to be mindful of the trailing haptic and just tuck it away so that it is centered well, and put the other trailing haptic also in the sulcus. In this scenario, for additional stability, we are doing an optic capture. So once the optic goes behind the fibrotic capsule, it is very stable. What about the scenarios when there is no sulcus? Well, there are some options like anterior chamber IOL, iris claw lenses or iris clip lenses, or scleral fixated IOLs. Well, for AC IOLs, the indications could be no PC support, scleral weakness or irregular iris support like in Marfan syndrome or Beal syndrome, no peripheral anterior synechiae or deep AC, and corneal diameters between 10 to 12.5 mm to reduce the chances of corneal decompensation. Adequate sizing, just like an ICL I would say, is very important for ACIOL as well to prevent corneal decompensation. And these are small kids. They have 80 to 90 years to live. So you have to be very accurate with the sizing, and PI is mandatory in these cases. What about iris claw lenses? Well, they are a very good option. Here's a video, the second one, where we are putting a 2-clip lens. You fill the space with OVD, the anterior chamber, hold the lens, gently clip both the claws. This is a retrofixated IOL. You have to just ensure there is adequate vitrectomy which has been done before the implantation of this. Otherwise, you may end up with GRTs if you're not careful with your vitrectomies. Now, what we have recently started at our center are 4-claw IOLs, especially with the smaller eyes. So what about those cases? Less than 9 mm eyes? Well, in these cases, we are using 4-clip lenses which are relatively smaller, though they require a certain amount of surgical dexterity. We have dexterous mentors with us. Here you have to enclave all the 4 claws, first claw being enclaved, then the other one at 3 o'clock. Now these lenses are smaller, so they provide us an additional advantage of implanting lenses in the smaller eyes. It has a significant surgical curve, but once you master it, you can give visual rehabilitation to those cases as well in which we were leaving patients aphakic. The last claw is the most challenging one, but you can use an additional instrument. In this case, we are using a Grieshaber serrated forceps for additional support and using just tucking up the 4th lens. So 4 claw sits very beautifully, though there can be some limitations. Like the pupil may not dilate as much as with a 2-clip lens. The other limitation can be explantation of these IOLs or IOL exchanges later may be a little difficult, but yes, you can provide this as an option to also patients which we were leaving aphakic earlier. Scleral fixated IOLs in kids, yes, people are discussing about putting SF IOLs, but with elastic and thin scleras, SF IOLs can be an issue. There can be haptic extrusion, there can be melting of the tissue, so you have to avoid scleral fixated IOLs, especially in kids less than 6 years of age. So to sum up, the prognosis and counseling is very important. Tartela et al. Proved that visual acuity improved after surgery in 83% of the eyes, and our experience is also that improvement in central steady maintained fixation in approximately more than 80% of the patients, which was also demonstrated by Khurana et al. And the key to pediatric cataracts is regular and long-term follow-up, pre-operative counseling with the parents, and making them a part of our team. Thank you so much. I had a nice time.